Reiter's syndrome, which we don't use anymore. Psoriatic arthritis, inflammatory bowel disease related arthritis, and then undifferentiated spondyloarthritis. And the kind of imaging findings that we're looking for with these diseases, you can see what's called anterior spondylitis or Romanos lesions, which we'll go through. Discitis itself, which are Anderson lesions, which involved changes to the end plates. Ankylosis, insufficiency fractures, syndesmophytes, which will show apophyseal and costovertebral arthritis, and enthesitis that we'll show here. So as we'll see, a lot of these findings are not specific for spondyloarthritis, so you'll need to put it in the context of the clinical syndrome and other imaging findings which we see. Another classification. Hey, John.
Thank you.
So spondyloarthritis. One of the findings that is common with spondyloarthritis is sacroiliitis. MR scan is really the best imaging technique to make this diagnosis. What we're looking for is what's called BME, bone marrow edema, but in reality, most of these are areas of inflammatory cells that replace the fat cells. So it gives bright signal on the fat suppressed images, but it's not always increased fluid in the interstitial spaces. So a lot of it's not really true edema, it's replacement of the fat cells by inflammatory cells. And if it's seen in one region which is large, or two regions which are smaller, centimeter or less, then you have to be very suspicious. And you look for other areas to confirm it. Most of the time with these diseases, it's pretty definitive when you look at the edema pattern. Now, one thing that's important to try to get a history, which is often difficult for radiologists, is what are the characteristics of the patient's symptoms. Inflammatory back pain tends to start younger, under the age of 45. And in ankylosing spondylitis, it's very common for it to be in the teenage years. And that's something you have to really be careful of because as we'll see, as we'll talk about here, it's very important to make this diagnosis as early as possible and treat the patients before they have irreversible disease. And they can get irreversible disease in their mid-teen years. If their back pain is less than 3 months, then it's very helpful. You'd like to make the diagnosis in that time period. It tends to be primarily in the morning, and then it tends to get better in the afternoon or with exercise. It tends not really to improve with rest, but more with exercise. And it can be alternating. So those are the typical findings. With ankylosing spondylitis, things they look for is sacroiliitis, which is commonly seen with ankylosing spondylitis. It typically is HLA-B27 positive, and then you look for two other spondyloarthritic features, which we'll go through in a minute. Age should be less than 45 in these papers, but I really think the diagnosis should be made before the age of 20. If you generally after that, you're talking about a lot of disease that's irreversible and you've kind of missed the boat. John, do you have any comments?
Usually when you see somebody at the age of 12, 13, 14, et cetera, and they come in with back pain, and you can't find anything on x-ray, which number one, you should have done a good examination. And one thing I've always done on back patients was to examine their chest expansion, which usually in this disease, ankylosing spondylitis, the expansion is less than half an inch or 3/8 of an inch. In that vicinity. It doesn't go any further. Usually it's about like a quarter of an inch or less. And then examination of the SI joints, you just percuss at those areas and you get pain, but you go up further, usually you don't have any pain. So that kind of gives you an idea that you have sacroiliitis going on. And my treatment has been conservative. There's nothing else really to do. And in the old days, nowadays, you can treat the disease. The sooner you can pick it up with an MRI. My one advice that I gave patients was, number one is don't use a pillow, don't elevate your head, because these people get kyphosis when the disease goes up to the thoracic area. And usually that prevents kyphosis, or it should help prevent it before the patient gets to be of age when it doesn't progress anymore in terms of stiffness. So that's about it.
Thanks, John. So in John and my days, there was really no treatment for this. Now there is very effective treatment. So that's why it's very important to make the diagnosis early now, as opposed to in the past. The spondyloarthritic features that you look for to help nail down the diagnosis are inflammatory, like back pain, like we just talked about, other areas of arthritis, enthesitis, especially in the heel, uveitis, dactylitis, psoriasis, Crohn's and ulcerative colitis, if we're looking for spondylitic arthropathies, not just ulcerative colitis. I mean, not just ankylosing spondylitis. They tend to respond symptomatically to NSAIDs, but these really don't treat the disease. They do not stop the progression. You need to really TNF-alpha inhibitors and more modern medicine to stop the disease. They tend to have a family history, HLA-B27 positive, and an elevated CRP, according to this particular basis. And studies have shown that MR can pick up the findings in ankylosing spondylitis about 10.5 years before an X-ray does. There are things that we can see with X-rays that you can't see that I'll show with MRI, but that the inflammatory changes, which are the early thing that you want to treat so that the X-ray positive findings never develop, MRI picks it up much earlier than X-rays. So one of the findings is called anterior spondylitis. These are also called acute rhamnous lesions, and these are these shiny corners. And typically instead of having rounded corners, they'll be sharply pointed, and you'll get areas of what looks like bone marrow edema within the bones. But again, this is really osteitis within the bones and inflammatory cells on the corners here. So pick that up. And that's relatively specific as opposed to the Anderson lesions we'll talk about in a minute, which are much less specific for inflammatory bowel disease. For spondylitic arthropathies. Later on, you can look for syndesmophytes. Those are these very thin, delicate ossification of the anterior longitudinal ligament, which we see here at the disc space levels. These are very difficult to see by MR. These are osteophytes here, which are not syndesmophytes, which we can see here that are being filled with fat. The actual syndesmophytes themselves are this very thin ossification of the anterior longitudinal ligament. And then you can get what some people call discitis, other people call Anderson lesions, which are basically look like a small nose with edema surrounding them. These are very commonly seen in middle-aged and older individuals with degenerative disc disease. We often call them Bodick changes. So these are much less specific for
one thing.
Inflammatory disease.
Excuse me, John.
Go ahead.
The longitudinal ligament is calcified, and that's pretty obvious on the MRI. which
Let
are
me
not
answer that.
so obvious on X-ray until later on.
Well, you can see the ossification really well by X-ray, not so well by MR. But the inflammatory changes we can see by MR, and you don't see them very well by X-ray until they're really later, which we can see as these sclerotic areas. And notice that the edges of the disc are not rounded like they normally are. They're very angulated, which is typical. So this is late disease. At this stage, this patient has fusion of a lot of these discs, most likely very poor motion, and this is irreversible disease. So we've really waited way too long in this individual. Go ahead, John. And there's further examples. Let's see, Daniel.
14-year-old male with back pain. You can see stir sequences, sagittal, showing some increase, increased signal within the posterior elements, the facets at, I think that's like L3, 4, or 5.
So now a lot of people get concerned. You've got degenerative disc disease here at the L5-S1 level. It's only a 14-year-old, but it's in a previous lecture that we gave here, and you haven't seen that, I don't think yet. These are actually, getting degenerative disc disease is not that uncommon in teenage, especially boys, especially athletes. So you're concerned about this, but the really concerning thing here is the edema adjacent to the posterior elements here, the facet joints. And if we go to the axial images, you can clearly see that there's a lot of edema around the facet joints, especially on this right side, which is very abnormal. In a 14-year-old with pain, if you're a clinician, you'd want to check to see if it's inflammatory type pain, like we just talked about. But this is highly suspicious of an inflammatory arthritis. And at this age group, the most common one by far would be
Ankylosing spondylitis.
ankylosing spondylitis. Thank you. Great. And then what do you think of the SI joints here?
Yeah, so there looks like there's some inflammatory changes along the SI joints.
So you can see the edema, a little bit of kind of erosive change. This is the diarthrodial part of the joint right here, and you can see these bone marrow, the osteitis within the ilium here, and this is a typical appearance of sacroiliitis in this young fellow. And just one thing to remember, if you're dealing with young women who are postpartum, is that you can get a lot of SI joint injury during the birth process.
That disease is 20% male to, 20 males to 1 female in occurrence. I've never seen a female with this disease myself, and I've seen a lot of back pain, and I've seen ankylosing spondylitis. Not my share of it. I don't know how many, but it's quite a few.
Good. Elior.
Okay, 13-year-old male with low back pain, T1 sequence on the left, water-sensitive sequence on the right. We see edema, osteitis on either side of the SI joints. Concerning for sacroiliitis.
Yeah. And here you can see some sclerotic changes on the left, a little irregularity of the subchondral bone, probably early erosive changes on the right. And this was early ankylosing spondylitis. And at this stage, this tends to respond very well to TNF-alpha inhibitor and the more modern anti-inflammatory drugs.
As far as I remember, I don't think they're symmetrical. Usually one joint's a little faster than the other, so
that's right.
There's no symmetry to it.
Yeah, it can be asymmetric. That's right, especially early on. And then here's a more severe example of sacroiliitis. We'd like to pick it up before this because you're already getting irreversible subchondral erosive changes in this patient and subcortical erosive changes down here with osteitis on both sides, maybe Anderson lesion up here. This was ankylosing spondylitis. Robert.
All right. So we have an 18-year-old male, negative hip aspiration for infection, HLA B27 positive, CRP positive. Evaluate for left hip pain. Looking at that left hip, there's a lot of edema in the femoral head and adjacent acetabulum. A little bit irregularity of the articular surface of the humeral head, but I don't see a definite fracture, and there's a big joint effusion with synovitis.
Yeah. And the SI joints?
SI joints, looks like there's some erosive change on the right with some, abnormal erosive. Yeah.
Right. So this patient's had, go ahead, John.
Yeah, as you can see, the right is quite involved. The left is sort of fairly normal looking.
Yeah, just like you said, asymmetric. Now this patient's had disease for a while. This isn't the early acute phase, so it'd be nice to have picked it up earlier. The reason you can say that is initially you get edema in the subchondral bone. Then what happens is that once the inflammation starts subsiding, what you get is replacement of the normal marrow cells with fat cells. And so this is the chronic phase or the post-inflammatory stage of this particular disease. So it'd been nice to pick this up earlier when there was patient was symptomatic earlier and had less. This is probably going to be irreversible, but still, this is a patient who will do well if you contain the disease at this level. And here's just another example showing the syndesmophytes, these nice thin ossifications, and how very difficult it is by MR often to see the syndesmophytes. And here we see the romulus or shiny corner lesions, which we can see, which should make us very suspicious. But again, this is chronic disease. This isn't acute. You want to pick this up before you get the syndesmophytes, because obviously this patient has no motion at this level, or they'd fracture the syndesmophytes. So this patient has irreversible disease, and we missed the boat in treating this patient effectively. Tayson.
All right, 33-year-old male with back pain, rule out disc herniation. Looks like we have pretty advanced bilateral sacroiliitis with a lot of erosive changes bilaterally.
Yeah, and a lot of osteitis still involving the sacrum. Here's it just shows the stir and the PD fat set. And in general, I think the stir is a little bit more sensitive for these. John? Okay. And again, sacroiliitis. Dan?
19-year-old male treated by orthopedist for 2 years for low back pain now, 3 months bilateral hip pain. So you get some obliques of the SI joints and a lateral, all radiographs. Looks like you might see.
I think they're pretty unremarkable.
Yeah, okay, good.
Okay, so I guess you want an MR scan.
Yes, sir.
Well, those are the proper x-rays to take with this disease to see the side joints the best. One thing I think with ankylosing spondylitis, when you have sacroiliitis, it affects the joint on both sides. With degenerative disease or a pregnancy type of a problem with the side joints, you only see the problem on one side to start with, and may not progress. But with ankylosing spondylitis, both sides are affected pretty much equally.
Okay. Thank you.
So stir sequence, coronal views, one at the level like the ilium SI joints, one at the level of the hips. We can see some inflammatory changes, sacroiliitis, asymmetric looking, and similar appearance in the at the femoral heads, at probably enthesopathic changes there.
Yeah.
When I look at it, I see that on the left it's more acute, on the right it's a bit more chronic. So probably the one on the right side, the side joint has probably been diseased for a longer period of time.
Well, maybe the patient had back pain for 2 years, but has had hip pain for only 3 years. So maybe you're right, John. And then here we can see the sacroiliitis very nicely on the axial stir. So
clinically, when you pound the spine with the side of your fist, it's pretty easy to pick up the tenderness in the area where the disease is. And of course, with time, it usually goes upward and goes all the way to the skull.
Okay.
That's not that common, maybe because patients don't live that long, but I'm not certain of that. But I saw one case, I think I mentioned before, that when the patient got rear-ended in a truck, tail light broke, and it was obvious the patient had ankylosing spondylitis, and one disc space was intact, and all the other parts of the spine did not move.
Okay.
So they blamed it on the accident for the problem.
Okay.
Unfortunately, the defense didn't do a very good job on defense. The patient got money for that accident.
Okay.
But anyway, the orthopedic surgeon operated on the guy, which was kind of a ridiculous thing to do. And the operation failed. So if anybody had to be sued, it's probably the doctor should have been sued.
Okay. All right, so here we can see the sacroiliitis. We talked to the physician. He referred him to a rheumatology consult, and they made the diagnosis of ankylosing spondylitis. And then here's some old lower quality scans again showing sacroiliitis, chronic. This is really very, very far along, so it's too bad this was picked up so late. But actually, at this particular time, the most effective drugs for ankylosing spondylitis still had not been invented. So there's not a lot that could have been done at this particular time. And then as you go farther, there's the ankylosing part of ankylosing spondylitis. Like we talked about with rheumatoid arthritis, what happens is you get erosions on both sides of a joint. You destroy the articular cartilage. Bone loves to heal itself after it's been damaged. And in the healing phase, the osteoclasts don't recognize that there's supposed to be two bones here, so they just heal the bone across the joint space, and you get fusion in ankylosing spondylitis. Okay, who's next?
Me.
Okay.
So we have T1 on the left, stir on the right. We see fusion of the vertebral bodies,
Yeah.
the upper lumbar, lower thoracic spine.
Yeah, all levels are really fused here. And this is, again, end-stage ankylosing spondylitis.
Yeah.
Okay, Robert.
All right, here we have a 23-year-old male with 10-year history of back pain. And looking at the anterior end plates, there's edema. I think that's L1, 2. Yeah, there. So I'd be concerned about inflammatory arthropathy there for sure.
Maybe here, maybe a little bit there. So you'd be concerned about that. And what do you see with the SI joints?
Here it looks like there's fusion of the superior SI joints already. So.
So again, we're a little too late on this one.
And the joint looks like it's fusing.
Yeah, it's fused, right?
All right, 51 male with trauma. Looks like he does have syndesmophytes and a fracture at the four.
So one of the big risks in this disease is a fracture. You get osteoporosis because you're not really using the spine much, the bones much anymore. You decreased activity, and then you've got this long, rigid rod, so you can get high levels of torque on a long rod if you fall, and so you can get a fracture.
This also shows something we see on X-rays. Is bamboo spine. That was pretty famous in our orthopedic literature.
Right.
One of the diagnostic findings on X-ray.
Yeah, again, you hope not to see this anymore in this day and age, but it's a bamboo spine. Good. And then there's the fracture on CT, and then the 3D showing the fracture. Okay. Who's next? Dan?
Yeah. 62 female.
I don't happen to know. Maybe somebody can tell me the longevity of individuals with this disease. I'm sure it varies because sometimes it's slow and sometimes it burns out and stops. But I'm quite sure that these people live probably 10 or 20, 30 years less in time than normal individuals.
Yeah. John, I think when we were in medical school, it was significantly decreased, like 30 years. We don't really know now because the effective drugs have only been around for like 25 years. But I think most people feel that if properly treated, they'll have a normal life expectancy now.
Yeah, I would imagine so, John.
66-year-old.
This is a pretty rare case right here as a female.
66-year-old female with ankylosing spondylitis. We can see fusion of the SI joints. We can also see that there's like expansion of like the dural space. Pretty consistent with dural ectasia.
Yeah, good. And you can see that fusion of the spine here. There's that dural ectasia. It can look like other things too. Well, let's see. This is not the case. Good. Okay.
It sometimes makes me think that it's a different disease from those of males. I don't know why, but it's so darn rare in women.
Okay.
This is the same.
And girls, I never saw a 12 or 13-year-old with a girl with this disease.
Okay.
Okay, so radiograph on the left, T1 MR on the right. So
these are the shiny corners.
Okay. Some sclerosis there.
Right. And then what do we see on the right?
So the facet joints were just some marked degeneration, sclerosis.
Yeah, this is kind of erosive change and irregularity and subchondral osteitis. We're just seeing a T1 weighted image here.
Okay.
But that's the shiny corners on X-ray. And apophyseal disease, like we saw earlier, Dan had the case, is a common feature of this. The other area, and John was saying that one of the things he always measured was chest expansion. And the reason you lose chest expansion is because the zygoapophyseal joints are a favorite place for this particular disease. And so you get a lot of inflammation and injury to the zygoapophyseal joints, which causes pain with expansion of the chest. So these people become diaphragm breathers rather than chest wall breathers. And then here's just the cervical spine. We can see edema within the soft tissues adjacent to the nuchal ligament here, which is also enthesitis that you can see in these diseases. Okay, Robert.
All right, so here it looks like there's some dural ectasia, some scalloping of the posterior spinous process there.
Right. Good. And then the other thing that we see here is marked atrophy of the spina erector muscles. You know, why do you think that may be the case?
Maybe they've had surgery, or I'm not entirely sure.
Yeah, well, they have fusion of all the joints in the spine. So, so you yeah. Okay, Tayson.
All right. So these
Yeah,
are
actually, this is another case with dural ectasia. And here this is actually a fused disc, and you can see that there's a lot of fat in the fused disc, and here's another bamboo spine. So, with laminar erosions. Okay, why don't you take this case?
right. 60-year-old female, right?
I'm sorry, let's forget this case. I don't want to show this case. Forget this. Sorry about that. Okay, well, there are some congenital variants that you can see in the sacrum, which can lead to sacral problems. Here's kind of the normal appearance of the sacroiliac joints in someone who's asymptomatic. You can get accessory facet joints, which we can see down here, in this case posteriorly. This is posteriorly and inferiorly. This is the fibrous portion of the joint. And you can see hypertrophic bone formation here and irregularity. This is called an accessory sacroiliac joint, and these can be painful, and this is a congenital lesion. You can get iliosacral complexes here, where you can get degenerative changes here from irregular joint space, and you get these horns on each side, which increases the risk of injury during motion and can be a problem. And then you can get here another list of abnormal shape of the sacroiliac joints. You get what's called a bipartite bone, where you basically have these little horns down inferiorly. You get these semicircular defects, which we can see here. You can get unfused ossification center, and then again, a lack of good coherence here with just abnormal, congenitally abnormal shape to the iliac bone. So there are a number of these that have been described, which can lead to traumatic injury to the sacroiliac joint and pain. And MR is pretty good at looking at these. Okay. Okay, Tayson.
All right. So we have a bone scan here showing increased uptake in the lower lumbar spine there. All right, so at L3 and L4, we have a lot of irregularity there. So trabecular,
Yeah, thickened vertical trabecular bone, right?
yeah.
Okay. And then here you can see those thickened trabecula in the axial plane. So what's this?
With that intense uptake on bones, can maybe fibrous dysplasia.
I think, starting to think about fibrous dysplasia, this happens to be Paget's disease. Okay, Dan?
49-year-old female, intermittent low back pain for 20 years, severe back pain, onset 2014, left hip pain, elevated ESR, CRP. I'm assuming, I don't remember those numbers off the top of my head.
Yeah.
Myocardial infarctions, defibrillator implantation 4 years ago. So we see a few levels on this sagittal CT of sclerotic changes, indefinite bony remodeling at those levels as well.
And some signal inhomogeneity, some like fat replacement here, maybe contrast enhancement, but we don't know since we don't have a T1 fat suppressed pre and see the sclerotic changes on X-ray.
So we see at the clavicles, there's a lot of confusion.
Yeah. So what are we thinking about here?
Bone scan, uptake on the clavicle, also on those spots right there in the low back. And also at the
patient has skin lesions.
Yeah. So we're thinking probably could be SAPHO.
Yeah. Good. With multiple areas of, and this is associated with chronic recurrent multifocal osteomyelitis, which is inflammation that can often be migratory within the bones, which is not caused by a known infectious agent. Okay. Thanks, everyone.
Thank you.
Thank you.
Thanks, John.
Thank you. Are you hanging out?
What's that?
Are we done?
We're done.
Well, have a good afternoon, everybody, and
We'll see
we'll
you
see you
tomorrow.
mañana.
Thank you.